Hello, my name is Evan Nadler, and I'm the director of the Children's National Weight Loss Surgery Program at Children's National Hospital. Today I'll be speaking to you about an update on bariatric surgery in children and adolescents with severe obesity. The goal for this talk will be to touch on the need for child and adolescent bariatric surgery, to describe the key components of a weight loss surgery program for kids, and to discuss expected outcomes for laparoscopic sleeve gastrectomy, which is my preferred procedure for children and adolescents. Severe obesity affects about 9 million adolescents in the United States. These children suffer from a lifetime of obesity-related medical problems, a shorter life expectancy, and an overall reduced quality of life. And overall, obesity costs the U.S. healthcare system approximately $173 billion a year. So it is imperative that obesity is treated early. What are the solutions available? The typical solution included in every weight management program is a diet and behavior modification program. That generally doesn't achieve much weight loss, so the addition of medications for weight loss and then bariatric surgery are often the next steps. And in children, there are dedicated child and adolescent weight loss surgery programs like the one we have here at Children's National. So I mentioned before, the treatments for pediatric obesity include an intensive lifestyle management. And unfortunately, this is more effective at preventing obesity than it is at actually treating obesity. So those who have already become severely or have already suffered from severe obesity have limited weight loss, and they often regain weight when the program ends, and it's particularly less effective in some of the minority populations in the U.S. The addition of pharmacotherapy can be quite helpful, and there are better and better weight loss medications that are being approved for both adults and adolescents with severe obesity. The weight loss is not as great as it is with surgery, but it is significant. But again, it has the issue of weight regain if the medication has stopped. And then here in the United States, a unique problem is that these medications aren't always covered by the insurance companies, and thus the expense may be great. When it comes to bariatric surgery in adolescents, we have seen excellent results from national consortia like the Teen Labs group, and then with my personal experience here at Children's National. We see a mean reduction of about 26% of the overall BMI. And this is accompanied by significant improvements in most of the major comorbidities, especially type 2 diabetes or insulin resistance and obstructive sleep apnea. We also have published on how this impacts the child's brain and how it improves their psychosocial outcomes. We use the same criteria for children and adolescents that are used for adult bariatric surgeons. These were established by the National Institute of Health back in 1991 here in the United States, and basically include a BMI over 40 or a BMI over 35 with a serious comorbidity. And all of the patients undergo some sort of medical weight loss program prior to surgery. In the United States, we have a accreditation body known as MBSA-QUIP, or the Metabolic and Bariatric Surgery accreditation and quality improvement program. And for children and adolescents, there are two different distinctions. One is an adult program that also will perform surgery on adolescents. And then there are separate criteria for a children's hospital like ours, where they perform bariatric surgery either with or without an adult bariatric surgery co-surgeon. Perhaps the most important part of the MBSA QIP requirements is that they outline what additional components are necessary for the optimal outcomes in children. Obviously, there's a bariatric surgery lead, a pediatrician or medical weight management lead, and then the additional components include a behavioral specialist, which is usually a psychiatrist or a psychologist who has some adolescent experience, a registered dietitian, and then either an exercise physiologist or a physical therapist, so that we can prescribe activities and other weight loss adjuncts with respect to exercise. So our program here at Children's National is the busiest in the United States, and we've performed 650 primary laparoscopic sleeve gastrectomies over the 12 years that I've been here, and a smattering of other cases along the way. Our average patient is about 16 and a half, female, and in our cohort we have a high prevalence of ethnic minorities. And in the last portion of the table, you can see that the patients generally have a smattering of different comorbidities, with insulin resistance, which isn't listed there as the most common, but frank diabetes in only about 15% of our patients. So how do the patients do after surgery? So at the time of surgery, our average patient weighs about 137 kilos with a BMI of 49. And by a year post-op, they've lost 36 kilos and 13 BMI points, more or less. There is a slight uptick in weight between 1 and 2 years after surgery, and this is where continued medical therapy or diet and behavioral therapy can be of great value. With respect to complications, this is a table from a publication back in 2017 when there were about 450 patients in our cohort, and at that time we had only 3 staple line leaks and a couple other unique complications in the 30-day perioperative period. Since that time, over the last 5 years, we've had a couple more patients who have had staple line leaks and a variety of other patients who have had PO intolerance and eventually required a cholecystectomy or some other surgical intervention. But overall, the risk of complications from surgery remains about 1%. Who should we consider for surgery when they are a child or adolescent, or who makes a good surgical candidate? Well, at our center, we have no lower age boundary for consideration for surgery, as long as the patient is suffering from severe obesity and is interested in weight loss surgery. However, if I were starting a new center, I would likely limit the boundary for the lower end to the teenage years, since those patients are best able to assent to surgery. All the patients have a BMI greater than 35 with a comorbidity, or a BMI of 40 without, And certainly any child whose BMI continues to trend upwards despite diet and behavior interventions and or pharmacotherapy should be considered. Some of the myths that are out there include that if a patient has a mental health concern or a cognitive disability, that they are not candidates for surgery. We view that these patients can have excellent results, and have seen that in our cohort and published on the topic. And thus, we just deal with the mental health concerns that we identify and then support the families that need extra support to optimize the surgical outcome. The biggest myth for children and adolescents is that if a child or adolescent isn't trying hard enough, that they won't have a successful surgical outcome. This is untrue in that the changes required to have a successful surgery are far easier after the procedure than before the procedure. When should you consider surgery for a child? For us, it really just is when the BMI crosses into the eligibility range and the family and child are interested. It can be when lifestyle management isn't working, because most of these families have already tried significant changes in the household prior to coming for a surgical evaluation. And certainly if there are comorbidities related to the child's weight, such as insulin resistance, type 2 diabetes, obstructive sleep apnea, or any other issues that significantly reduce the child's quality of life, we feel it's important to get the child in for an evaluation. We don't offer surgery until the child and family are both well prepared to move forward. So in conclusion, bariatric surgery is the treatment with the most success for children and adolescents with severe obesity with respect to both weight loss and resolution of the medical problems associated with their obesity. A low BMI is the best preoperative predictor of outcomes. And I didn't speak about this in the talk, but the sooner a child or adolescent, and same goes for an adult, the sooner any patient comes to bariatric surgery, if they are suffering from severe obesity, the better, as that makes the comorbidities more easily reversed, and as well as each procedure comes with a finite change in BMI. So the lower the starting BMI, the lower the end BMI. Referral to the surgery team should not be a last resort, but should just be part of the overall treatment plan discussion. And we've incorporated a discussion about surgery at the actual initial visit for any patient into our medical weight management program if they meet the criteria for surgery. So it is often that a patient may hear about surgery on their initial visit, but not decide to move forward with surgery for 6 months or a year later. And lastly, regardless of any other confounding variables such as a mental health or cognitive disability history, we believe that all children and adolescents with severe obesity can be considered for surgery if you have the right support systems in place. So I thank you for listening and watching today. And if you have any questions about my talk, please feel free to email me. My email is there, enadler@children'snational.org. Or you can call me, although an international phone call may not be feasible. So just email. Thank you again, and I appreciate your attention.